Good day, everyone, and welcome to the 9-month progress report. My name is Dénes Kovács, and let me invite you to a walk of about the etiology of the adverse pregnancy outcomes. So, my name is Dénes Kovács. I'm a resident of the Obstetrics and Gynecology department of our university, and my mission is to emphasize the importance of prevention and to help improve reproduction rates. And also, my vision is that all people should be able to create a healthy family. These are my specific goals. These are two meta-analyses. One is about, the first topic is about the investigation of human papillomavirus infection on adverse pregnancy outcomes. We have started this project last year, September, and we have already finished it, fortunately. And the second one, let's talk about it a bit later. So this is the first topic, and we know that HPV is very important because of its oncological relation, because of this German professor, Harald, who discovered that HPV is very much related to cervical cancer. Not only cervical cancer, but different ones as well. And he also received the Nobel Prize for this in 2008. And we also know that HPV is one of the most widespread and common sexually transmitted infections worldwide, with a lifetime prevalence of estimated about 80 or 90%. We also know from in vitro studies that HPV can cause malfunctions in reproduction, such as inhibit blastocyst formation or endometrial implantation, or can cause apoptosis in embryonic cells as well. And from observational studies, we know that it is associated with a bunch of pathological entities, such as preterm delivery or premature rupture of membranes, well, among other things as well. So the results are conflicting, and therefore we aim to assess the pregnancy outcomes in women infected with HPV. Our question was that, are adverse pregnancy outcomes more common among HPV-infected women? And so our population was the pregnant women, of course, and their exposure and control groups were the HPV-infected and not if-infected population. The outcomes were all the adverse pregnancy outcomes that I've listed here. And our hypothesis was that HPV infection can actually lead to an increase in said pregnancy outcomes. So the clinical the implication was this to emphasize the importance of prevention. We have conducted a systematic search on the 10th of November last year using the following search key with two domains. One was about human papillomavirus, and the second domain was about all the pathological entities that we were looking for. And this search has yielded 7,070 articles, from which, after duplicate removal, title, abstract, and full text selection, we have managed to get the 22 articles together. Now, we have finalized all the analysis for these said outcomes, and our outcome measure was odds ratio with a 95% of confidence intervals. And so, this is my first forest plot. This forest plot is about the occurrence of preterm delivery among HPV-infected and healthy control groups. Our effect measure was odds ratio, and the effect size was 1.62, which was definitely clinically relevant and statistically significant as well. Unfortunately, however, throughout my whole the other forest plots, you will see no statistical significance, as we have not managed to prove a connection between HPV and, for example, premature rupture of membranes. As you can see, this is the case as well with low birth weight and also with spontaneous abortion as well. The strengths of this study is that it is quite comprehensive with a lot of outcomes that we have included, and also the large sample size was a very big plus as well, and the rigorous inclusion criteria too. However, there are many limitations to this study. One was that different strains of HPV were pooled together, which can cause some bias, and also the high heterogeneity. Confounding factors were not very well defined in these studies as well, so we could not retrieve many data on this. So what is the take-home message about this? We know that HPV is linked to preterm delivery, however not associated with all the other pathological entities that we have discussed. And what does this mean for everyday patient care? It means that we should test the patients more frequently, and also test the pregnant patients as well, and maybe vaccination before family planning would be advisable. And what does this mean for the future? It means that vaccine is needed for more strains, and also treatment alternative is paramount, need of it. And also studies should be conducted on the effect of vaccination and adverse pregnancy outcomes as well. The manuscript is completely finished, and we have just submitted it. Our aim is to publish this article in Pregnancy and Childbirth. And let's take a closer look about my second topic as well, which is investigating the association between lipid profiles and various pregnancy complications. So we all know that these total cholesterol, low density lipoprotein, high density, and triglyceride levels are all part of prenatal care. And we also know that the levels are changing throughout the pregnancy, but this usually does not result in any therapeutic action. So we also know that it is associated with preeclampsia and gestational diabetes, among other things as well. And we need more information on what the normal levels, what the reference intervals are for lipid levels throughout the pregnancy. And therefore, we aim to understand the effect of different lipid profiles, and if possible, then we would like to set cutoff values as well. Our question is that can total cholesterol, HDL, LDL, and triglyceride levels be associated with adverse pregnancy outcomes? Of course, our population are pregnant women, and the exposure is dyslipidemia. Our hypothesis is that maternal dyslipidemia characteristics are actually indicative of future pregnancy outcomes. So the clinical implication would be that this would be a great diagnostic tool in prenatal care. And we have conducted a systematic search on the 23rd of May with the following search key that was made of two domains. One was with all the adverse pregnancy outcomes, and the one was all the lipids that we have included. And so this is the progress of it, and we are hoping to get the full text by the beginning of July. So this is the overview about my two topics, and we are hoping to submit by the fall this year of the second topic. So thank you for your attention, and as you, if you know the way broadly, you will see it in everything. Thank you.
I have a short question for your second project. Did you find any previous meta-analysis on this topic?
Yes, there are several. Thank you for the question. There are actually several previous meta-analyses. They are just not as comprehensive as what we aim to do. They are only specific on either gestational diabetes or preeclampsia.
Nice progress. Thank you for your presentation. Regarding your first project, you mentioned vaccination before the family planning. What's your suggestion, or what did you find in connection that underwrite the pregnancy, the vaccination underwrite the pregnancy? Is it recommended or not, or any recommendation?
Thank you for your question. So during pregnancies, that's where it's not much advisable. Therefore, it would make more sense to vaccinate the population before actually getting pregnant.
Can you formulate again your conclusion, your answer to Dr. Tirso, when to vaccinate? Because it is important.
Before getting actually pregnant.
Can I have a question to you?
Yes.
Isn't it too late? Because there is a lag time between start of your sexual activity and you might even gather some HPV, and between starting of sexual intercourse till your family planning.
Yes,
so it might be 10 to 15 to 20 years. Yes. Why not vaccinating before the onset of sexual activity?
So the most sound thing to do is what the professor has advised, and of course this is the nationwide direction that we are going in, that we should all vaccinate. We should all get vaccinated by the age of 13 or 14, and this is very much true for the girls as well, but we should do this with the boys too. And if somebody, for some reason, haven't taken the vaccine when they were 13 or 14, and they didn't get vaccinated, well, they should catch up, meaning that they should definitely get the vaccination before.
Yeah, I totally agree with you. I just wanted to express that your results, your meta-analysis may be added to the parents who are dealing with young daughters before vaccination. So this is an additional reason why to let them vaccinate.
Definitely. Yes.
Of course, I understand that there is a subset of women who did not get it before 13. I have a second question.
Yes.
What were the conclusions of previous meta-analysis you have already mentioned?
Okay, so
They were limited data as you formulated just recently, and what were the conclusions of those meta-analyses?
So the literature is heterogeneous about this as well, but one major difference between my meta-analysis and previous meta-analyses is that they have associated preterm delivery, not only preterm delivery, but premature rupture of membranes as well with HPV. And we have not found an association between these two entities.
I see. Fine. I have a third question. Can you make any difference, or in these 22 publications that you have started to go into details, make any difference between the risk groups of HPV, whether it is high risk or low risk, and whether the identification has been performed by Roche technique that is always reproducible all over the world. So this is the gold standard. And you might have only 3 results or 4 results. Either it is negative or HPV 16, HPV 18, or other high-risk HPV. Were all these studies, these 22 studies, did they use the Roche technique, or everyone has made his homemade PCR technique?
So
can you recall it?
Yes, the mode of diagnosis was actually very different throughout all the articles, because they are from a lot of countries throughout the world, and some have used the PCR technique, some have used only the Pap smear, the Papa Nicolau screening mode, and if they had a different, if they had a bad screening result, some of these articles have used this as a proxy for HPV infection, which is a major cause of bias, of course.
Okay. Can you record the total number of patients included, pregnant women? About, not exactly, of course.
It is somewhere between 400 and 500,000. The whole, and okay. They're very different articles. Some are case reports with a population of maybe 80 patients, but then there are nationwide registries which have a few 100,000 people. And of course, from which not everybody was tested for HPV, which is another major cause of bias as well, yes.
Thank you, Dr. Kovács. We enjoyed it very much.
Thank you very much for your question.